Доброго вечора, українські радіаційні онкологи, медичні фізики та радіаційні терапевтичні технологи. Слава Україні! Дякуємо, що приєдналися до Modern Brachytherapy course with ABS Experts for Ukraine. My name is Sergey Brovchuk and I'm a medical physicist at Lisot Israeli Oncology Hospital in Ukraine and Alexander Shamyov National Scientific Center of Surgery and Transplantation. I will be co-moderating this lecture with Arjit Bakwala.
Hi, everyone. Good evening. Again, huge honor to be involved in this project. My name is Arjit Bagwala. I'm one of the physicists at Houston Methodist Hospital, involved in brachytherapy. And brace yourselves, it's a huge honor to introduce Dr. Todor with us today. Our lecture today is on brachytherapy treatment planning, and we are honored to have an amazing speaker for our lecture, Dr. Dorin Todor, a professor at Virginia Commonwealth University, or VCU. Dr. Todor received his PhD from Old Dominion University. He then completed a fellowship in medical physics at Memorial Sloan Kettering Cancer Center in New York. In November 2001, he joined VCU as an assistant professor in the Department of Radiation Oncology. He was promoted to associate professor and became the director for brachytherapy physics service in 2010. In 2020, he was promoted to full professor. Dr. Todor managed and supported the brachytherapy service and contributed directly to almost all LDR and HDR treatments at VCU: prostate, breast, GYN, sarcomas, eye plaques, endobronchial, pancreas, etc. In his clinical service, Dr. Todor participated in and initiated several clinical trials while implementing in the clinic and leading the latest recommendations and guidelines from the professional societies such as ABS, ASTRO, AAPM, and ESTRO. He taught, advised, and mentored many students and graduate students as well as junior faculty colleagues. In recognition of his national level of expertise, he was on the board of associate editors of medical physics and associate editor on the editorial board of Brachytherapy and Red Journal, three of the major publications in the field of radiation oncology. Dr. Todor was the chair of the ABS Physics Committee from 2017 to 2019 and is the co-chair of the APM Task Group TG236, which is recommendations on 3D image-based treatment planning, dosimetry, and quality management for intracavitary brachytherapy. A steady presence in the ABS and AAPM teaching schools, Dr. Todor has been invited faculty to 16 schools as well as invited chair and speaker at international conferences: ESTRO 2019, 2024, World Congress in Brachytherapy 2012. Dr. Todor's clinical research focuses on better understanding the correlation between radiation treatment parameters for breast, prostate, and gynecological cancers and clinical outcomes. He holds 3 patents in breast brachytherapy, a very active area for both the clinic and clinical research. Dr. Todor's longtime efforts and active participation have been translated in authorship for 2 major societal guidelines, ASTRO and ABS. Again, thank you so much, Dr. Todor, for your time, and the floor is all yours.
Well, thank you for the introduction, Git. I appreciate. And thank you, Natalia, for inviting me. It's an honor to give you this lecture on brachytherapy treatment planning. I know we have 15 minutes at the end for questions, but I would encourage you, if during the lecture you see something and you feel like it's the right time to ask a question, you can always feel free to interrupt me. I will now share the slides I prepared with you. Okay. Can you see my slides?
Yeah.
Okay.
Great. Perfect.
Cool. Okay. So I have to disclose that Natalia gave me this assignment, so it wasn't entirely my choice of talking about brachytherapy treatment planning, even though it's one of the subjects that I feel like I lecture many times, and you'll see the reasons why. What we have. Oh, Okay, so while the generic title is treatment planning, what we are going to try to cover today is going to be essentially treatment planning strategies, both in HDR and LDR, TG43, which is probably the most commonly used dose computation formalism, at least in brachytherapy. And then we are going to touch a little bit on treatment planning systems, commissioning, and QA. So that's pretty much what's on the menu today. And on the first subject, the treatment planning strategies, here is sort of an outline, so you guys know what's following. It's going to be a little bit of history, talk very succinctly about asymmetric systems, and then a quick overview on how the professional societies see planning, and you'll see the reasons for that. And then, since it's easier to discuss about planning when you have actual cases, I picked 3 cases. One, it's a hybrid tandem and ovoid cervical cancer treatment, and it's hybrid because it involves both the tandem and ovoid and some free-handed needles. And then the second case, it's a breast interstitial implant, one of which we treated just 10 minutes ago. So we have a pretty high volume of this type of treatments here, and we have done this for the last probably 20 plus years. And a prostate HDR case. So these are sort of examples of the most commonly treated sites for cancer treatments involving brachytherapy. And then towards the end, we'll talk a little bit about LDR. I will be honest with you and tell you that we haven't done an LDR case here in probably more than 10 years. We used to be quite active, but for reasons which are going to become more clear during the presentation, you'll see why we gave up on LDR and prefer to do HDR these days. So for all those of you who have a little bit, more years under the belt in doing, radiation oncology, you will probably recognize these images. I have seen them myself. So essentially, these are sort of the simplest way of planning a tandem and ovoid using 2D planning. So essentially, the all you see here is applicators, and then you can describe some points that are not the actual anatomy, but surrogate points for some of the organs of risk. These were applications with cesium-137. You can see the sources are pretty chunky. We haven't done cesium in probably more than 10 years. We don't even have the cesium sources anymore. And this was planning associated with those 2 images. And by the way, these 2 images I didn't explain, but this is an APPA type of orientation. This is a lateral. So essentially, out of 2 images, you are able, if you see the sources in both images, you're able to retrieve the 3D coordinates, and then those 3D coordinates were plugged into a treatment planning system that, again, we don't use. It's Pinnacle, for those of you recognizing the look of the isodose lines. And then planning or optimization essentially was not much to talk about. You can see here the sources, the cesium sources were described by the nominal activity measured in milligram radium equivalent. And we had 16s and 12s and 25s and 3s. So essentially, it was pretty much a very simple way of combining these very few categories of nominal activities into what looked like, your typical pear-shaped dose. So optimization, it's a big word. There was very little. And again, for those of you who have done these kind of things, you might remember that you were not actually prescribing or computing dose, but you were rather computing dose rate. So these treatments, for the longest time, they were supposed to deliver somewhere around 50 centigrade per hour. And then depending on the total dose that the physician described, you would just wait, 2-3 days. So the patient would be somewhere in the clinic in a shielded room, away from everybody, just getting this, continuous low dose rate exposure. Here are, some of the points. So for example, in the ICRU 38, which now it's replaced with the report number 89. But in 38, essentially you had this magic point, which was a rectal reference point and a bladder reference point, but they were just surrogate points for the actual rectum or for the actual bladder. Here's another example, going on memory lane on interstitial breast implants. Interestingly enough, the breast implants look very similarly with what we do today, with the exception that we are not placing low dose rate seeds, but we are using high dose rate delivery. But the idea was the same. You would have two orthogonal films, so two different orientations. You can read on this one, it's 90 degrees. On this one, it's 145, or obliques, if not orthogonals. And each catheter had some markers, and preferably the markers were different from one catheter to the other. So essentially, you would digitize this, and out of two views, you would be able to retrieve the 3D implant. And then the implant would be essentially the dosimetry for the implant would be computed not in a volume, but in a central plane of the implant. So amazingly enough, we cured patients even with these very rudimentary methods. Now, a reasonable question is, this being the history, how did we got here? And the way we got here essentially was by building on decades of successful clinical experience and relying on clinical knowledge, sublimated, if you want, in collections of rules that were called systems. So these systems, you can tell by their name, originated in various places. We have a Stockholm system, we have Paris, Manchester, Fletcher. It's not a place, it's a person. So Fletcher was actually, the Fletcher system was a refinement of the Manchester system, which originated in the UK. Fletcher was a physician practicing at MD Anderson, and this is where the system essentially evolved. If you look at the dates at which the system originated, we are starting with 1910 for Stockholm, and then 1919 for Paris, 1938 for Manchester, and Fletcher was much more recent, as in 1960s. Anyway, the idea that this system essentially described how things should be done. Okay, so they represented practice. People have tried different things, and they mostly use their common sense on how do we best place these radioactive sources, which, by the way, at the time they were mostly radium needles. How do we place them to get some uniformity or some sort of making sure that we are delivering, the right amount of dose, even though the concept of dose wasn't around at the time. the treatment really was prescribed based on milligram of radium. So milligram of radium and time were the only descriptors of treatments. However, there was many decades of people having created treatment plans or implants based on these systems. And then somehow we made it to today. Now, today, or the modern era, if you want, started pretty much with the introduction of CT in the 70s. And it was about that time when we had concepts like exposure and later dose. And then, you know, in the 90s and early 2000, we learned how to really transport radiation, sort of the computational part of it. And then I think it was in the 80s when the first treatment was described by something that we commonly use today, which is a descriptor of the dose distribution, which is a dose volume histogram. So that's pretty much where we are now, and that's where we came from. So, okay, here we have the first set of questions. Sergey, are you taking this?
Yes, I will launch the question.
Okay.
You can
Yeah,
read.
if you don't mind reading it, then it would be also subtitled into Ukrainian. It would be easier for them.
Okay. Okay. Should I do that?
Yes, sure.
Okay. So the question is, the traditional brachytherapy dosimetric systems, Stockholm, Paris, Manchester, Fletcher, that guided practice for decades were primarily based on, and you have four choices. Choice number A, it's mathematical modeling and biological optimization principles. Choice number two, B, is clinical experience, standardization, and reproducibility of successful treatments. C, modern dose volume histogram analysis, and D, computer-based inverse planning algorithms.
Yes, so we have about 75% of people answering. I think
Okay.
we'll 87. Good.
Okay. Are we still waiting, or this is the end?
You can end the poll and share the results, and you can comment on the answers.
Okay. Well, most people, 42%, got the right answer, which is clinical experience, standardization, and reproducibility of successful treatments. As I said, at the time at which these treatments originated, or these concepts of treatments originated, we didn't have anything describing dose or dose optimization, or even concepts like, you know, biological effects and things like that. So essentially what people did by creating these systems was, well, it seems like whatever we did here kind of works, so let's repeat that. So essentially it's a way of reproducing successful treatments. There was not a lot of insight into this. Sergey, I have a little window here that says, can I just close that?
Yeah, you can close that window.
Okay, cool. Okay, so let's continue. In the next couple of slides, I'm going to give you sort of a little bit of insight onto how different professional societies are thinking about the new era of high dose rate brachytherapy as far as planning, okay? And planning goes hand in hand with the term of optimization. So essentially optimization is planning that satisfies in an optimal way a set of criteria. And of course, the criteria are usually coverage of whatever you declare as target and avoidance of whatever are the involved normal anatomy. we call those organs of risk. So in 2012, the American Brachytherapy Society created these consensus guidelines for carcinoma of the cervix. And in this text, they describe that the term optimization refers to the sophisticated process of achieving certain dose values at points of volumes within the implant, and it is not the simple generation of standard dose distribution by using fixed dose points. But then they go in saying this, that optimization should be performed with caution by observing changes in the dose, as well as the spatial dose distribution that results from a modified loading pattern. Underline, it's a pretty bold statement, which I disagree with, which is the exclusive use of dose volume histogram-based parameters to select a source loading. It's not recommended. Now, you can argue that, well, maybe they changed their opinion because that was 2012. And let's look at the most recent one, and this is not the American perspective, but rather the European perspective. So you have, a review article describing 3D brachytherapy for cervical cancer, new optimization ways. So let's see how they look at this. So they describe what manual optimization is, and then they say, well, in general, inverse planning is not recommended, and manual optimization is preferable, which kind of like voices the same ideas that you've seen earlier as presented by the ADS. Now, we disagree with that. I disagree with that. Because I think in this day and age, everybody should use inverse optimization. And I'm going to try to make the case of why is that true. Now, in 2015, so 10 years ago, we published this paper, which presents an actual solution.
Смотри, сдай назад, я немножко по-другому.
Excuse me.
Apologies. Is it okay? You can continue. Apologies.
No, okay. If somebody wants to ask anything, just let me know, okay? I can
No,
stop.
it was an error, hot mic.
Okay. So what we recognize is that the real difficulty in pursuing an exclusive dose volume based optimization stems from the fact that in cervical cancer in particular, just using the planning targets and the anatomy, those elements are not enough to drive by themselves an optimizer towards a standard pear-shaped dose distribution. It's as simple as that. I mean, in many other situations like prostate or breast, the structures involved in the planning are enough to drive the optimization towards your intended treatment. That's not true for cervical cancer, and the reason is not true is that the practice based on these dosimetric systems evolved for a long time, and for a long time, essentially, we created these pear-shaped dose distributions like you see here. So the solution that we presented was kind of like trying to meet in the middle, kind of like a Buddhist middle way, if you want. So the two steps that we created, and that's an actual, it's not that we published this. We published this after we had used this method for a while, and we are using it today. So what are the two steps? Essentially, the two steps are creating this very traditional, very classical pair dose distribution. You can see here that the implant also has two needles, and the two needles here, you can see that even in an intuitive way, you can see that the target, and the target is the structure in orange here, it's larger than what a normal traditional pair, which is about 4 cm in width, would be able to accommodate. So these two needles are supposed to help with coverage in that area. But the way we do this is we create the pair distribution just using the tandem and the ovoids. And then most treatment planning systems, including Varian and Electas, allow you to convert an isodose line into a structure. So essentially, we create now a structure that is the pair itself, okay? The next step, and you can see that the dwell times in this tandem and ovoid are pretty contiguous. And I'm going to come back to this idea of contiguity as a feature a little in a few slides. But anyway, so we create a pair distribution, we convert it into a structure, and then we are creating an additional structure. You can call it a CTV or a PTV if you want, by summing the pair with a high-risk CTV, the structure that was outlined here in orange, okay? So we get this composite structure, and in an ideal world, you would create a dose distribution that fits exactly this structure, okay? Now, to help the optimizer, we are also creating a structure that is just a planning structure, which is kind of like a ring structure right around this composite structure, okay? So what we have here in green is an avoidance structure. So essentially what we are doing is we are using the avoidance structure to limit the dose to the inside of the ring, okay? And you'll see that that greatly helps the optimizer. So now that's the final product, okay? So we optimize this plan by now allowing the dose distribution to be also determined by dwell positions that were established in the two needles. And you can see that it's not your typical pear. It's a different vegetable or a different fruit, but it mimics the pear. So you can see that the pear is still there, but it also fulfills the dose coverage on the high-risk CTV. And you can see here that it avoids much better than the initial pear, the bladder, the sigmoid, and the rectum. And here are a couple of the objectives. So in order to still keep the pear-shaped dose distribution, we use a little trick. So on that PTV, which is, again, the composite structure, we are using a little bit of a relaxed dose constraint. So for example, the dose constraint that we use in this case, it's the V95 should be greater than or no greater than 95% of the volume of the pear. So essentially what we do here is we have a little dial, if you want, that allows you to go between a classical pear. So a classical pear would be obtained if I go to 100 to 100. Okay, so that would force the isodose lines to really feel the original pear, but that's not what we want. What we want is some in between this, classical pear and, the ugly looking but very conformal squashes, if you want. You can see that the dose constraint that we use, for example, for the high-risk CTV, it's much higher. We require 98% of the volume of the structure to be covered by at least 98% of the volume. And then the avoidance structure, which is that ring structure around the PTV, essentially what we are telling the optimizer, we don't want isodose line to go into that ring. So the isodose line will have to be contained to the inside of the ring. And then we have very tough constraints for the sigmoid. So for example, we require that no more than 0.1 cc's would get 60% of the prescription dose or more. And we have a similar one for rectum and bladder. And by using those constraints, essentially you allow the optimizer to still get something that is roughly resembles the pair, but conforms much better to your target. So that's our little trick. And you'll see that trick, it's essentially replicated for other sites. And here are the dose, not the dose distribution, the dwell times in the tandem and the ovoids and the needles. And I can tell you that there are people who look at this and they would not like it. And the reason they don't like it is these people like the contiguous dwell times. We don't have enough time here to get into this subject, but the beauty or the contiguity of the dwell times has nothing to do with the quality of the implant. Okay, if you hear otherwise, tell them that they are not right. And you can see here the difference between the two dose volume histograms. This is the original pair. So the coverage is not bad, but it's not great. You can see this one is the coverage for the optimized plan. And then you can see here all the organs of risk from the sigmoid, the bladder, and the rectum. In the optimized version of the plan, they get much lower doses. Okay, and we got to the next question, which is, why is exclusive dose volume histogram based optimization challenging in brachytherapy, particularly for cervical cancer treatments? A, it's dose volume histogram parameters are too difficult to calculate accurately. B, it's the explicitly contoured structures alone are insufficient to guide the optimizer towards appropriate dose distributions. C, its inverse planning algorithms cannot handle more than 3 structures. D, its manual optimization is faster than any automated approach. Okay, I can see almost everybody got the right answer, which is B.
We will have to wait a little bit more. I think
Okay.
half of people answered.
Okay.
Now you gave them the answer. It's gonna
I
be
know.
great.
I know. I should have waited. Yeah.
Okay. They got it anyways.
Okay. Wonderful. Okay. Okay. So let's keep going. You know, I will tell you that since we'll have another lecture in 3 weeks, I think. It's going to be in the middle of November on breast interstitial implants. I'm going to discuss a little bit more, and maybe I'm going to have a live case, so you're going to see it kind of like in real time how this goes and how fast it goes. But for those of you that haven't seen one, this is how an interstitial implant looks like. So we put catheters, and this is how it looks in real life. So there are these plastic catheters that are hollow going through the breast. And yes, it looks a little bit medieval, but it's you know, very well tolerated. We used to do these treatments in 10 fractions. These days we do them in 3 fractions, so the implant is in the patient for just 1 night. You can see the catheters are hollow plastic tubes. We like to see them really well in CT. So what we do is prior to the CT, we put a very thin wire in each of the catheters. That way you get something really bright instead of something really dark, which we find it's easier to outline. And you can see the dose distribution. These treatments, so for breast brachytherapy, it's an adjuvant treatment. So the first line of treatment is surgery. So the surgeon goes and essentially scoops out the tumor. Now, if you don't do anything, the recurrence rates are quite high in their 30s and 40s. So to reduce the recurrence rates to, you know, single-digit percentages, essentially you have to do this adjuvant radiation treatment. One way of delivering this adjuvant treatment is through interstitial brachytherapy. What you see here in pink, it's an outline of the outline of the lumpectomy cavity. And then the treatment, it's a certain margin. In this case, it's 1.5 centimeters margin from the lumpectomy cavity. You can see here the projection. So this is the typical skin surface dose that patients would receive. You can see this is probably the 60% of the prescription. And this is how we plan this structure, these treatments. So essentially, the physician is the one describing the lumpectomy cavity, and then the planner creates these additional structures, these additional targets. This is the CTD 1.5 centimeters. And then in a very similar way with the cervical cancer, we create one structure that is going to serve two purposes. One is going to allow you to automatically populate dwell positions inside all the catheters that are inside of this structure. And then it's also going to create this ring structure that has pretty much the same role of containing the prescription dose inside. As I said, in 3 weeks, we are going to have another chance, and I'm going to present a live planning so you can see exactly how it happens. And on breast brachytherapy, unlike GYN or prostate, both of which the tumor is present, remember that in breast brachytherapy, the tumor is not there. So what we are treating is breast tissue that is at risk for recurrence. Because of that, we are imposing a very, very severe constraint on the V150 and the V200. You can see that they are very low. And the reason for that is that there is clinical data showing that the level of inhomogeneity correlates with toxicity. So in order to minimize toxicity after the treatment, you need to minimize the inhomogeneity. So you can see here in this plan, we require that the V150 should be less than 10% of the volume, and the V200 should be less than 3%. So these are extremely homogeneous treatments, even though we're talking about brachytherapy, which is inhomogeneous by definition. Our metric is either V100, as you can see here, or V95. This is a great treatment. The V100 is greater than 96%. And you can see we are always evaluating the V150 and the V200. So that got us to the next question, which is interstitial breast HDR treatment plans are optimized for choice A, it's minimum of dose inhomogeneity. B, it's maximum of dose coverage to the target. C, it's minimum of dose to the skin. And D is all of the above. So A, B, and C. Okay, you let me know when you think we are
We
ready
can
to
wait a
go.
little bit more, just
Okay.
more answers.
Well, should I give it away?
I see people still answering, but
Okay. Well, most everybody got the right answer, which is all of these things, and they are right. So I think I did a better job explaining this time. So we'll stop here. Okay. The next case, kind of like example, is going to be prostate HDR, and I will have a disclosure on this one. The case that I'm presenting here, at least I'm actually presenting two cases. The first one is based on CT, which we haven't done in the last 23 years. With the exception of 2 years in which we had a physician that was very keen about doing these cases, planning them based on CT, even though traditionally in brachytherapy use ultrasound to guide the insertion of the catheters. Right now, what we are using, it's an ultrasound-based planning, but for reasons who are going to become clear, hopefully in the next few slides, I'm going to show you this case. So this is a prostate HDR. You can see all the needles in the prostate here. You can see also outlines the bladder, the urethra, rectum. The planning strategy is similar with the previous two cases. We have a structure, which is this ring, which is a simple margin on the prostate that it's going to use to automatically populate all the needles with dwell positions inside of the structure. And we also create that ring structure that is going to contain the prescription dose. So essentially the prescription dose is going to be outside of the prostate and inside of this ring. So that's going to ensure that the optimizer, the reason the ring structure is so important, imagine that you don't have a ring structure, okay? And imagine that the only structure on which you are going to impose constraint is going to be the prostate. And you're going to tell the optimizer, make sure that I get 100% of the prostate receiving 100% of the prescription dose. That's fine. What the optimizer is going to occasionally do, depending on the placement of your applicators, is that there is no limit to how much of the tissue outside of your target is going to be irradiated, okay? So what you would like to do to convey to the optimizer is a term, you can, if you would be able to tell the optimizer in natural language, oh, by the way, I want this level of coverage, but make sure that it's conformal. So essentially, it's the conformity of the dose to the target that you are enforcing by adding to your structures this ring structure, okay? We do a couple of tricks. So for example, even though we outlined the urethra by not the urethra, but really by the Foley catheter, you can see the Foley balloon here, to account for the fact that the actual urethra is larger than the Foley, we create another structure here. You can see it in orange, which is an expansion of the urethra, and we put the actual constraints on that. The physician we used to work with also had kind of like a very idiosyncratic desire of delivering a higher dose to the peripheral zone. But while he liked to hand wave the peripheral zone, he didn't spend the time to outline the peripheral zone. So in order to allow the optimizer to do that job automatically, what we came up with was a little trick. So we would do this very funky looking asymmetric expansion of the urethra, which is what you see here in pink. And then we would use that to subtract it from the prostate. So you would get this structure in orange that it's pretty much what one would outline as a peripheral zone. And you can see that on that particular structure, we require that a higher level of dose, like 100%, 120%, to be received by at least 90% of the volume of the structure, or 150 to at least 55%. So that just to make sure that you get this extra hot peripheral zone. And you can see here the final product, and you can see that in all these peripheral zones, you get, so 120 is that color, and 150 is the blue. So you can see that 150 and 120 is delivered contiguously, and there are lots of 150% spots. You can see that here. So it's you can see that you get really good avoidance of the urethra. The urethra definitely gets less than prescription dose, while the dose is very conformal to the prostate. Now, these days, as I told you, we are doing ultrasound-based insertion and planning. And sometimes we have an MR suite adjacent to our brachytherapy suite. So sometimes we use MR to boost dose to a particular foci of disease that can be delineated in MR. So what you see here, it's an MR image. We delineate the prostate. You can see very well the zonal anatomy of the prostate. And in red here, you can see sort of the index lesion for this prostate. And then we superpose this on the actual images that we use for planning. Now you can see that while in the sagittal plane, you have a pretty good match of the urethra as it was delineated in ultrasound and MR. In the transversal view, you can see that there is a little bit of a shape change. That's mostly because the MR image in this particular case was acquired with a rectal probe. We don't do that anymore because, as you can see, the rectum is really large here and distorts the prostate. But we account on that by placing a margin that presumably accounts for the slight difference in registration of the prostate MR with the prostate of ultrasound. This is more or less typical implant. You can see that because of that particular foci of disease, we added an extra needle to make sure that that volume is going to be extra hot. And again, the result from inverse optimization shows you that this particular part of the prostate, which is the foci that was identified in MR, receives in excess of 150%, while the rest of the prostate gets this very, very conformal dose. Now, that's pretty much the strategy as far as various high dose rate cases. Low dose rate, it's a little bit different, and you'll see why. Low dose rate in most places is based on ultrasound, and in most places people acquire maybe a week or two before the implant, they acquire what they call a volume study. So essentially they acquire a set of images and they create a pre-plan based on those images. And on those pre-plan, they insert needles. You can see that here, and each needle has a particular loading. The loading is essentially the succession of seeds. You can see here in yellow, and the spaces between seeds, which are called spacers. You can see here an example of that particular pre-plan in a sagittal image. You can see more clearly the loading of the needle. And this is pretty much how the plan looks like. So the question is this an optimal plan? How do you go about planning these kind of cases? And there are very many strategies, and I'm just going to describe you a few. But the implant, while it's done in most places based on ultrasound, in most places, the quality of the implant is evaluated by a CT. The CT, sometimes it's acquired the very same day. We call the day zero CT. Sometimes people wait a week or 2 weeks or 30 days. There are all sorts of philosophies. The idea is that You have a dynamic process right after the implantation. The prostate swells. So ideally, what you would like to do is get the imaging session in which you evaluate the implant at the time at which the swelling has subsided, and maybe you have the same prostate that you have implanted, but at the same time, you have other dynamic things like the seeds, the LDR seeds are decaying every day. So you have a decay of the seeds. What you are doing is essentially take this one shot, of the prostate and the geometry of the implant, and then you assume that the whole delivery is done in that particular configuration, which is an assumption. And that's one of the reasons for which LDR, it's never, in my opinion, as good as high dose rate, because you never quite know what that implant delivered, okay? As far as loading, there are many philosophies, but I will describe here two. One, it's a sort of a standard loading, which is this needle here, needle number one. The standard loading is just a regular succession of seeds and spacers. The custom loading is everything that is not standard, and you can see these two needles here, 4 and 14, have a custom loading. Now, there are lots of practitioners who would never do what you see here as a custom loading. They will always do a standard, and there are others who would do other ways. As far as quality assurance, most people do a radiograph of the preloaded needles. So essentially, if it's to recognize needle number one, the radiograph is this one. This happened to be palladium seeds, in which the markers are showing as two little blobs at the ends of the seed. So, but you can recognize here 3 seeds, which are this one and this one and this one. You can also recognize in 4 and 14. So essentially, it's a way of checking that the loading that you have created in the plan, it's the loading that you have actually delivered into the patient. So here are kind of like some diagrams. Some people do pre-planning, other people do intraoperative planning. If you use pre-planning, you have a session in which you just image the prostate and then you create a pre-plan. And then within the next week or 2 weeks, you receive the seeds, you calibrate the seeds, you sterilize the seeds, and then you load the seeds in needles, or you can just send the loading plan to the manufacturer and order preloaded needles, so you don't have to really do anything. They usually come pre-sterilized, and already you get a film that shows you that they produce the QA for you. If you do intraoperative, so essentially intraoperative means that the patient only comes at the day of the implant. So just prior to the implant, you do acquire the volume study, and then on the spot you create a plan, but then you have to have a way of either inserting the seeds using a MIC applicator, or you can use a loader and preload kind of like on the spot needles and then hand them to the physician who's going to insert them in the patient. Now, the same way we describe, in HDR optimized plans, here we can raise the issue of, is there a better needle loading plan? And the answer is mostly a good or a better plan will be a more robust plan. Robust to what? Robust to the uncertainties of inserting the seeds in the prostate and the seeds staying where you inserted them, which is also a little bit of a question mark. So in order to define robustness, we found that it could be useful to compare the pre-plans with actual implants. Do they resemble? And if they resemble, does it matter? So I'm going to skip over this, and I'm just going to give you one of the papers that we published, essentially examining the relationship between the pre-plan and the post-implant geometry. Essentially, our conclusion was that the geometrical similarity between a pre-plan and an actual implant, while could be useful, doesn't seem to be necessary to achieve the right dosimetry. So resemblance in the geometrical terms was not a prerequisite. Okay, so we have one more question, which is, what is the primary advantage of HDR over LDR for prostate cancer? Choice number A, it's no radiation sources left in the patient. Choice number B, better outcome. Number C, needing a shielded room for treatment delivery. Or D, a better control in shaping the dose. Now that's a little bit more difficult since you don't have that much of an obvious choice. But remember that the idea is, what is the primary advantage of HDR over LDR? What do you think, Sergey? Should we still wait, or are we good?
Yeah, we can wait a little bit. Let's see how they do. So 85% answered, maybe a few more answers.
Okay.
Please. 87.
Okay, so I think the only conclusion here is that there is no one good answer. You know, I do agree with the people who said, well, you know, the advantage is that there are no radiation sources left in the patient. But I also agree with the people who said better control in shaping the dose. If I have to pick one and say which is the primary advantage, I would go with the group that said better control in shaping the dose, because you have the placement of the sources, and in HDR, you have a chance of optimizing those. You don't have that in LDR. So, but I think you got this right. Okay, so we are going to talk a little bit about TG43, which is by far the most commonly used dose formalism in LDR and HDR. And I'm not going to dwell a lot onto this. The TG43 was introduced in 1995 and then revised in 2004. This is the formalism essentially, and you can see here that you have different factors. So you have one factor that accounts for the air camera strength of the source. It's another factor here, gamma, that is accounting for the dose rate constant in the water. So for example, for a certain isotope, iridium-192, no matter what source we use, whether it's Electa or Barian, it's going to have the same gamma, the same dose rate constant in the water. And then you have a geometry function, a radial dose function, and an isotropy function. You can also see that the formalism is two-dimensional, and it's two-dimensional because most of these sources are little cylinders, and because of the cylindrical symmetry, all you have to do is be able to describe those in one plane, okay? So to describe in one plane, you either need an X or an Y, or if you use polar coordinates, you need an R and a theta, okay? So that's the reason. So once you are able to describe one plane, then you're able to describe the 3D plane, because all you have to do is rotate that plane through the axis of your source. So that's pretty much how we calculate those for all HDR treatments and LDR treatments. Now, is there a choice? Yes, there is a TG, I think it's 189 or 86, that describes a more sophisticated way of computing dose if you want kind of like a real dose. But we are going to see the next couple of slides. Is that necessary, and why is that necessary, and why isn't? So the way we implemented that in the clinic is that in order to compute those using these formalism, you need to either know the 3D coordinates of the centers and the orientation of the source, or you can just get the two ends of the source. Okay. The dose rate contribution then from each source is calculated using either a one-dimensional or a two-dimensional algorithm, and then each of the contribution is summed up to determine the total dose rate. Okay, and by doing that, you are assuming that there is no source-to-source shielding effect, which is obviously in HDR because you only have one source that just moves around. That all tissues in and around the implant are water equivalent, and then the scattering volume within the patient is equivalent to the one used in the consensus data set. To put it succinctly, the TG43 assumes two things: infinite water world. So everything is water-like and everything is without margins. Now, I'm quite sure you're all familiar with, so I'm just going to try to just skip through this very fast. The most important thing, probably if you don't remember anything from brachytherapy dosimetry, the one thing you will have to remember is the inverse square law. This is mostly for students, but for whatever reason, I'm going to reiterate. The inverse square law, it's a very universal law. It's not specific to brachytherapy. A lot of other things vary as an inverse square law. For example, if you have an electric charge and you compute the intensity of the electric field, it varies as the square of the radius. If you have a planet and you calculate the gravitational field somewhere outside, it varies by the same law. The reason it's universal is that in its essence, it's a reflection of the three-dimensional space in which we all live, okay? If we would live in a two-dimensional space, the inverse square law would not be that, would be like 1/r, okay? So another thing that it's also very interesting, you can argue that, okay, the inverse square law, it's a reflection of the three-dimensional world, but there are other things competing. And you can see here 4 graphs describing the contribution of the primary and scattered photons, okay? And these are things that occur at all energies. So these 4 energies here were the energy for iodine, iridium, I think this is ytterbium, and this is cesium-137. And what's interesting is that, so all these graphs have extracted already the 1/r square, okay? So what you see here, it's just the contribution of the primary and scattered photons and the sum of it, okay? Interestingly enough, for the high energies like iridium and cesium-137, the total dose, sort of the total of these two contributions for distances that are of clinical relevance, which are, somewhere between 5 and 10 cm, so in this area, looks almost flat. So in a very convenient way, the primary the contribution of the primary photons decreases as the contribution of the scattered photons increases. And they very conveniently compensate each other in such a way that the sum of these two is constant. And because of that, the only other thing that is going to be reflected in the way the dose rate varies as a function of the radius is going to be the 1/r square, okay? But you are just assuming that you always get the full contribution of the scatter. And that assumption is sometimes not true. It is true if you have enough tissue around your sources that photons are always going to scatter back in your, wherever you are depositing those. Breast, for example, it's a notorious case when this thing doesn't happen because the source is very close to the boundary between tissue and air. So essentially, half of the photons that are emitted that way are not coming back because air is not enough to scatter them back, okay? Now, the situation is very different in the low energy. So you can see that in the low energy, even for clinical cases, you have a pretty dramatic variation just because of that, okay? Also interesting is that if I look at the CT, so a lot of these treatments are based on CT, okay? The question is, do we need a CT? And the answer is yes and no. If you look at so on this axis here, you have photon energy in MEVs. On the vertical axis, you have the mass energy absorption, the mass attenuation coefficients, and the collision stopping power. So you can see that, and these are all relative to the water. So one here, it's water, okay? So you can see that these coefficients here, as long as the energy of your source is greater than 100 keV, they all behave like water, even though they are very different tissues. You can have muscle, you can have mammary gland, you can have adipose tissue. If you are delivering those with a low energy source, you're in a lot of trouble. You're going to have to use that CT and be able to distinguish between these tissues. But if you're delivering those with iridium, which is 192, which is 380 kV, then you really don't have to worry because everything else is going to be water-like, okay? So that's why the CT density it's not taking into account. That's why we can get away using TG43. Here's a paper that I strongly recommend you to read. It's called The Evolution of Brachytherapy Treatment Planning. And these authors essentially looked at all these sites through the perspective of a high energy source and a low energy source. And then they decided whether the formalism using, the TG43 simplification is good enough for these sites. And you can see that, for example, for breast, treatments delivered with a high energy source, the only thing that TG43 is not going to get correctly is going to be the scattering for the purpose that I just described. Okay, so we got our next question, which is the inverse squared law is A, specific to LDR brachytherapy, B, specific to high dose rate brachytherapy, C, a universal law, D, a universal law which reflects the three-dimensional nature of our world.
Dr. Todor, while the attendees are answering that question, there's a question in the chat.
Yes.
For prostate brachy, how do you account for the swelling in after the implant?
The short answer is you don't. The short answer, so there are clinics in which it's really a matter of what do you want to see, and do you have access to your patients after the implant. The beauty of LDR is that it's a one-time encounter with the patient. So if the patient, for example, lives hundreds of kilometers from the treatment cancer center, it's unlikely that that patient is going to come back a week or 2 or 30 days after the implant just for a CT. So just because you have access to the patient, you're going to very likely get the CT at the time of the implant. So maybe recover the patient and then get them to a CT scanner. So if you do implants at day 0, you are not going to get any you're not going to account for any swelling because probably the swelling right after the implant it's at its max. People have have done serial CTs and tried to find an optimal CT time in such a way that this dynamic of the swelling, getting resolved and the decay of the implant would give you that perfect view. And I think if you want to get that perfect timing, and there are a lot of assumptions, the answer would be slightly different whether you are treating with iodine and palladium because the half times are slightly different. But yeah, long story short, it's if you have access to the patient or your patient is going to comply to your demands, then probably 30 days for CT and maybe 2-3 weeks for palladium. I'm sorry, and 30 days for iodine would be the perfect time in which presumably you are accounting for swelling. But short of that, you're not. Okay, and I see most people got C and D. I mean, I was just being, yes, it's a universal law, and yes, it's a universal law that happens to reflect the 3D nature of our world. So I would go with both people who responded C and D got it right. So, okay. A few more minutes on treatment planning system commissioning and QA. And the issues that we are going to discuss here is data import and imaging geometry, source specification, dose calculation, applicator commissioning, library template planning, and data output. So all these things, let's suppose that you just installed a new treatment planning system. I mean, you can start using it. It assumes that it works as intended, but most physicists are going to want to test various things. One is data import and imaging geometry. I strongly recommend, particularly when you are about to do this, to read this. It's a very recently published paper describing precisely that, the commissioning and quality assurance of TG43 based brachytherapy treatment planning systems. You can see here that it was published in 2025 by my European colleagues. And this is a very well written document that should probably be a guideline for anybody who does that. There is a similar document by the AAPM, but I would recommend this as being the most recent one. And you can see that essentially they created these tables in which you have an overview of what kind of tests you have to deliver, what kind of tolerance is acceptable, and how frequent you should do this. So, for example, as far as imaging, I think one of the most important things of any treatment planning system is to ensure that the geometry of the real world, namely the patient, is correctly transposed in your treatment planning system. And in other words, is a centimeter in your patient reproduced as a centimeter in the treatment planning system? Are parallel lines in the patient reproduced as parallel lines? So you don't want distortions in the image or in the representation of your patient. Are volumes in the real world, are volumes in the patient correctly computed by the treatment planning system? So these are, I think, the most important things that you need to essentially check. And most conveniently, the way you check that is by using phantoms that have all these features, that have certain volumes that you can delineate and compute volumes, that have markers that you can compute the distance between them and things like that. one of the probably, if I would have to put a ranking of all these things, they are all important, but probably the absolute most important is your source specification. So every treatment planning system allows you to use a number of sources, and for each of the sources, you have a whole range of descriptors that essentially are the parameters of the TG43 formalism. And these are the very important things that you have to check. So again, I'm not encouraging you to just check one thing, but if I would need to just check one thing, I would check the source description. So, and the way you do this, it's you have documents that people have published that contain tables and parameters for very specific sources. And I think I have here, I have an example. So both the Europeans at the University of Valencia and the Americans at MD Anderson in Houston, they maintain sort of a library of all the sources that are in clinical use. And you can see here, MD Anderson has HDR cobalt sources, has HDR iridium-192 sources. So for each of those sources, these are, publicly available. You can just go there and retrieve all the parameters, then you can check against your treatment planning system. And the same thing in the University of Valencia database, you can see here, they have cobalt sources, cesium-131, cesium-137, iridium sources, both LDR and HDR. So that's another very important thing to do. And then, of course, you have tests related to the dose calculation. Now, when you do dose calculation, essentially, you can have two types of tests. One in which it's not really commissioning, but maybe more like acceptance, in which the manufacturer says, well, if you put a source of such and such air camera strength in such and such position, and you measure the dose to this particular point of coordinates X, Y, and Z, you should get that number. Okay, so that's one way of checking the dose computation. Another one is to do sort of a hand calculation using the analytical description of TG43, and then you would compare that with the result of your treatment planning system. And of course, you have those volume histograms and those volume histogram calculations that are important because they are the metrics that you're using for your treatment. Not at last, it's applicator reconstruction. So you have imaged a phantom or your patient with a certain applicator in place. You have to have a plan on how you're going to describe that applicator. Is it a known geometry? If you describe it using the tools in the treatment planning system, how close is your description from what you know the applicator looks like? In most of the modern treatment planning systems, you have library of applicators, and you can create your own library. But a lot of the applicators that you buy from Electa or from Varian have their own description. And sometimes these are the best way of using the applicators, because if it's a rigid geometry, you just bring the applicator and you overlap it over your actual CT scan or MR scan or ultrasound scan. And in most cases, you are doing much better in overlapping a library applicator than you would do by trying to describe it manually, for example. So all these things have to be checked. I will tell you that the library applicators in most treatment planning system, ours, I'm quite sure contains maybe tens or hundreds of applicators. It's unreasonable to do commissioning of all these applicators. What I think it's reasonable to do is the subset of applicators that we actually have in the clinics in the clinic or plan to use. But I wouldn't encourage anybody to use an applicator on which you haven't done the commissioning. And you can see here, that's the conclusion of the document that I was just sharing with you, that the brachytherapy treatment planning system allows the modeling of dose distribution under clinical circumstances. And given the capability and the complexity, if it's prudent, they say, so they don't say it's mandatory, but they say it's prudent to commission the treatment planning system for its use in a specific clinic with specific applicators. So that's pretty much all I have. So thank you for your attention, and Slava Ukraini.
Героям слава.
I think we have,
Heroyam Slava, thank you. That's such a nice slide. Love it.
and I think we have a couple of minutes for questions if you have any.
I do have one question. From the beginning, you showed planning on 2D planning, and we later learn that it is the ICRU point which we used on a Foley catheter. It might not be representative as a hottest dose to the bladder, let's say. So the hottest 2 cc's might not be in the same place at that ICRU point. But if you would need to plan nowadays on these images, what would be your strategy? Would you still consider this point? Or what would be your approach to not overdose bladder and rectum?
Yes, so I can tell you that we have a number of satellites, and up until maybe somewhere between 5 and 10 years ago, one of the satellites only had a simulator, and so they didn't have access to a CT. They only had a simulator, so you can just take, you know, fluoroscopic views or X-ray views if you want. So we were forced, even though we had a treatment planning system that was fully capable of volumetric computation, we were forced to use these 2 or 3 views. And you can do fine. I mean, people have wrote extensively when we moved from ICRU 38 to 89. I mean, there was a long period of time in which people had developed a lot of experience with 2D planning, but now CT was available, so they tried to figure out, you know, how wrong were we when we were doing, you know, point-based. The reality is that we have treated lots and lots of patients, and we did fine using, you know, point dose. We know now that point doses are not always perfect descriptors of, you know, the dose to the bladder, for example. Remember that what you see here as the bladder reference point is not really the bladder, it's sort of the posterior aspect of the Foley bulb or the Foley balloon. But, you know, if the physician is careful and they pull the Foley to sort of the neck of the bladder, it's a reasonable descriptor. So as a strategy, I would say that, and the same thing for the rectal reference point. I mean, most of the time people would put gauze with some iodine to get some contrast and put that in the rectum so you can get enough contrast and you can kind of see where the rectum is in the fluoroscopy or the X-ray image. So you get a reasonable reference point. What my strategy would be, if I would plan based on 2D, would be to maybe be a bit more conservative to what I would accept a bladder point and or a rectal point than I would be with a volumetric description. But other than that, I think you would be doing perfectly fine if you have to plan based on 2D. As
Yes.
I said, we've done this for a long time, and we've treated lots of patients. We cured lots of patients.
Dr. Todor, when you plan GYN treatments, do you still look at point A, point B, just a reference check, or it's all volumetric now?
It's volumetric. So when we created, in step A, which is creating that pair,
Right.
we kind of ballpark, essentially you want to create a pair that looks like a classic pair. So in other words, if I get a tool and I get a quick measurement of, is it 4 centimeters or around, I would not go to the length of putting actual A points.
Okay.
But I would make a quick measurement, and I would like to reassure myself that it's kind of like what I would have done. Sometimes you need it a little bit more, and sometimes you need a little bit less. I mean, if for example, your high risk CTV, it's entirely inside of the pair, there is no point in extending the pair to 2 centimeters laterally, if that interferes with your organs of risk. So, I feel like, yes, we are not looking at point 8, we are kind of looking, but it's mostly, I feel like we are living in this in between, for a long time, all we treated was pairs. And now we have, you can throw the MR imaging and you get these exquisite details of, high risk CTV, intermediate risk CTV, and so on and so on. But nobody's willing to give up on the pair and just treat the high risk CTV. So we feel like in this situation, our solution is kind of like the best of the both worlds. You are still creating something that resembles a pair. So whatever the pair did, you still do it, but you are also now using actively the optimization to maximize the dose to the high risk CTV while minimizing the dose to the organs of risk. So I feel like, until we are ready to just treat sub volumes of what used to be the entire pair, if that time will ever come, then I feel like this solution it's the best in between.
Yeah, that's a great answer. Thank you.
There's another question for you. Well, they start with, thank you for the great lecture. If TG43 does not take into account the presence of tissues of different densities, does not take into account the effects of shading and attenuation by applicated materials, the calculation is performed in an infinite water phantom, then which dosimetric system is better to use? Should we still use TG43 but take into account its shortcomings?
Yeah, I think that's a complicated question. We might need another lecture for that. I mean, it seems like a reasonable thing. You have a better way of doing things. Why don't you just do it? Why don't we just drop TG43 and just do TG186 and get real dose? The problem is not as simple as it sounds. Just because you have a better way, it doesn't mean that. So first of all, in high dose rate, you've noticed that TG43, it's fine because adding the complexity or the knowledge that you have, inhomogeneity in CT, you have different levels of gray, is not going to add any value. The only two circumstances in which you should be considering using acros, for example, which is a TG186 treatment planning system, it's whether you are using shields. So for example, if you're using a vaginal cylinder and you want to spare the rectum and you put a shield, a tungsten shield, obviously TG43 is going to be completely useless because it's not going to tell you how much you have shielded that, okay? Or for example, if you want to put shielded ovoids. So if you use shields, TG43 is going to be useless, okay? So you have to use TG186. Or, as I said, in the breast case, when you know that TG43, because it assumes a full scatter, is going to produce an overestimate of both the skin dose, if your sources are close to the skin, or of the dose coverage. The problem is that being wrong or right, it's not always easy, okay? And the reason I'm saying this is the following. You have decades of having acquired clinical data based on TG43, okay? And now you say, well, the 4.3 grade that I thought I'm delivering is not 4.3, but it's 4.1, okay? And should we make it 4.1? And my answer is, well, if you make it 4.1 under TG186, it's going to be exactly what you have done in TG43, thinking that it's 4.3. Okay, so you're not really the real issue is you have two systems. Okay, you have the old system here, the TG43, and then you have the new system here, which is 186. So I think I had a slide somewhere, but I'm not sure I can put it right now. The real issue is ranking. Okay, so for example, you have treated 1,000 patients, and they were all treated with TG43. Okay, and based on TG43 parameters, now you are able to describe, well, patients that got this level of dose got some toxicity, but patients that got this level of dose didn't get the toxicity, okay? And now you have this brand new treatment planning system that computes more correct dose, and you recompute your 1,000 patients, okay? Now, of course, because it's a better dose computation formalism, we are going to get different numbers. But the question is, if I'm ranking the 1,000 patients based on TG43, is that ranking going to change if I rank them based on TG186? And if the answer to that is no, the ranking is going to be the same, okay? You're just going to get lower doses, but this is like a stoplight. That's why my slide had two stoplights, okay? Imagine that you have red, yellow, green, okay? We all know what to do, okay? Now imagine that one day you stop to a stoplight and the red is not quite red, it's like pink. And the yellow, it's not quite yellow, it's kind of like orange. And the green, it's not quite green, but it's teal, okay? So the colors are slightly different from what you used to see, but the ranking of them, it's the same, okay? So the order in which they show. So even though the colors are slightly different, as a driver, we are all going to know what to do because you are saying, well, the top light, it's where the red comes. So even though it's not red, but it's pink, I still know what to do, you know? But now imagine that you get to a stoplight where the lights are not only of slightly different colors, but the green is on top, okay? So that's very confusing. I don't know if my analogy helped or confused more, but as I said, the real issue here did the ranking of the patient change, okay? Is what I used to think was a low dose in the new formal is becoming a high dose or the other way around. Because if that doesn't happen, and if everything just goes down one way or up one way, you're not changing anything, okay? So I think that's primarily the reason for which many years after we have derived and they are clinically available, these better dosimetric, you know, or planning systems, we are not using them actively because nobody wants to redefine what the prescription dose is You know, if you deliver for 3 decades GYN with a 7 gray per fraction, and now the new treatment planning system says, well, the 7 gray that you thought you're delivering is not 7, it's really 6.8, you know? You are not really changing anything, changing both the prescription dose and the dose formulas. You are doing precisely the same thing. So
Makes sense. Another question is, do you use 3D printed applicators for interstitial brachy in the treatment of GYN cancers in your clinical practice?
we don't, but I know somebody who does, and he just happens to be Natalia's husband, and I think he's going to lecture, and you guys are going to learn a lot. In our clinic, we use, for a number of reasons, I'm not going to get into, we are using these free-handed needles. So we use, our hybrids are sort of homemade hybrids. Electa, for example, has a whole host of very fancy hybrid applicators for GYN. And one can argue that you can do better printing, 3D printing your own, and you can. It's just that, in my view, if you can do it really fast, then you are really helping yourself and in the process helping patient. I've seen sites in which they are bringing a patient in the clinic. They are putting a tandem and ovoid under anesthesia. They get, they get an MR scan, and then they recover the patient and they send the patient back just for the purpose of printing, 3D printing something, and then they bring back the patient 2 weeks later. To me, that's borderline unethical. I don't think that's the right way of doing things. So I think Thomas is going to give you sort of the best way of using 3D printed applicators or accessories of applicators that they have used extensively in GYN treatments. So hold on, better things are coming. But okay, do we have any other questions?
We have one more, I think. Do you use TG186 recommendation in using heterogeneity correction for breast planning?
Sorry, can you repeat that? The TG186 in breast cancer?
Yes, in using heterogeneity corrections for breast planning.
Yeah, the only heterogeneity worth using, it's the fact that you have that boundary. I'm not aware of any clinic that decided to do their treatments based on TG186 for breast interstitial, for all the reasons that I discussed. You know that TG43 is going to be an overestimate. So for example, if you want to limit the dose according to TG43, the skin dose to say 100%, you know that if you recompute that case with Acros is going to say, well, you know, it's not 100, it's going to be, I don't know, 86 or 95, okay? But yeah, I don't believe that it's worth doing. And I am not aware of any clinic in which they are actively using 186 in the clinic. As I said, unless I'm using something that it's a dramatic change. So inhomogeneity is in the tissue, let that be breast tissue or any other part of the body, in HDR are not going to make any difference in the accuracy of your computation. Water is as good as tissue. If you are using shielding of any kind, then yes, you should use TG186 because that's where you get real dose. But short of that, for breast, no, or other sites, I don't think that CT inhomogeneity computation is going to add any insight to your, or any, it's going to make any better for the patient. But if you learn otherwise, I would be happy to hear about that. And by the way, I wish I put a slide with my email address. If anybody has any questions in your practice that I can help with, or any other issue that I can help with, you can definitely get the email address from Natalia. So please feel free to contact me. I would be very happy to help if I can.
Thank you so much. Thank you for being so generous and for offering to help. It's quite amazing. We're neighbors, right?
Absolutely.
So helping each other. Thank you. It was an amazing lecture. It was great to see all those examples, clinical site planning and TG43, and great discussion on the heterogeneity use. Thank you. It was a great general lecture. Now we're going to learn more about clinical site planning. So it's exciting. Next week, we'll have a lecture on Friday, not on Tuesday, Friday, on skin brachytherapy. Thank you so much, Dr. Todor. Thank you, Arjit and Sahi, for moderation. It was great. Thank you.
It was good.
Have a good evening, everyone.
Same here. Thank you so much.
Bye.
Bye-bye.